We are about to have the next session of the Clinical Neurology Forum. And this time, I have the pleasure of inviting the PhD Department of Neurology to present cases from their institute, Coimbatore. And also, I have the pleasure of inviting Professor C.T. Suresh, the head of the department of Indira Gandhi Government General Hospital and Research Institute at Pondicherry or Puducherry. I'll hand over to Suresh and ask him to conduct the proceedings. Welcome, Dr. Suresh, and please take over. Thank you, sir.
Yes, sir. Am I audible, sir?
Yeah, you are.
Yes, sir. Good morning, sir. Good morning. It's nice to be, sharing the 46th webinar, which has been conceived and coordinated by Professor V. Natarajan, sir. Guru for everybody. Yes, sir. And I welcome all the senior neurologists on board. I'm welcoming all the senior neurologists on board for this wonderful webinar session. Yes, sir. I saw him and took his blessing, sir.
No, your video is not seen. Video is not seen.
Sir, let me finish, sir. I think my video has a problem. I'll just finish off, sir. Let us start, sir. Already we are 10 minutes late, sir, actually. I invite Professor Balakrishnan, sir. He is MD, DM, DNB Neurology from PSG Hospital. He's head of the department. He's already presented here. And he's a wonderful man. And he has a lot of publications in his name. And he's going to present about the interesting case of stroke. That was topic 1. And topic 2 will be interesting case of myasthenic syndrome. I request Professor Balakrishnan, sir, to take over and present this interesting cases in today's 46th webinar. Balakrishnan, sir, please.
Yes, sir. I'll share it, sir. Can you see the slide, sir?
You can. It's in the slide share. You can open it out.
Sir, can you see the slide, sir?
Yes.
Shall I continue, sir?
Please. Full screen share pannidunga.
Sir?
Okay, 1 minute. That's okay now. Yeah.
You're seeing, sir?
Yes.
So this is about around the 50-year-old female, sir, presented with stroke to us. And the final diagnosis is very interesting. So I'll just start with this thing. The 54-year-old female. There is type 2 diabetes mellitus from 2006, hypertension since 2006. And she had a CA thyroid also, been operated. And she had a uterine fibroid hysterectomy done. And she first presented to us in April 2017 with 1 episode of seizures. That time MRI was normal, showing bilateral temporal subcortical periventricular white matter changes and cyst in the left middle temporal lobe. And but she was started on oxormazepine. She was well till November 2021. So at the age of 51 years of age, she had a sudden onset slurring of speech, mouth deviation, and left hemiparesis. And clinically, she had a mild left hemiparesis, left human facial palsy. MRI showed this is 10/11/2021. There is acute infarct coronary radiata and capsoganglionic region. And but M1 was normal. There is some luminal narrowing in the basilar artery and the right A1 segment. And the basic blood investigation, everything was normal, echo is normal. But she had a very poorly controlled diabetes and hypertension. We thought that stroke is because of the poorly controlled hypertension and diabetes. This is the initial first MRI. This MRI showing there is some narrowing, some beading-like features in this this thing, and some narrowing in the basilar artery also here. This is CT angiogram showing there is significant narrowing in the basilar artery and narrowing in the branches of middle cerebral artery and the M1 segment of right MCA territory. But large vessels are absolutely normal. ECG was sinus rhythm. Echo, there is no LV clot, and she was totally normal. And this is a close-up view of the circle of Willis showing multiple narrowing. So routine investigations done. Everything is like uncontrolled diabetes and uncontrolled hypertension. Otherwise, she is normal. She started on good control of anti-sugars and antihypertensives, and started on a single antiplatelets and statins plus low molecular heparin. And she started on mild physiotherapy and she started improving. And on 13/11, there is worsening of the left-sided weakness and worsening of there is new development of dysphagia. there is definite increase in size of the same capsule ganglionic infarct, and so we just adjust the dose of heparin, and we had a good control of diabetes and hypertension. 1511, she developed headache and altered sensorium. MRI showed there is small areas of hemorrhage transmission with a mild mass effect. So the aspirin was stopped and heparin was stopped. But we did an MRI and MRA repeated. But there is some new luminal narrowing in the right cavernous and left ulnar segment of ICA. And the basilar artery is also showed narrowing. So we had a suspicion of this strokes, 2 strokes. And because of the multiple small narrowing, we thought we had to do a vasculitic workup. And always we do a C3, C4, ANA profile, ANA, IF, APLA, ANCA. Even we have done a serum homocysteine. So everything is normal. So we had a suspicion of CNS vasculitis. So we did a DSA, and there is multiple smooth segmental narrowing in bilateral MCA, distal and like bleeding, and the distal anterior and post circulation. And the basal artery stenosis is also around 75%. So suspicion of CNS vasculitis, but the context RCVS is not fitting into this spectrum. The presentation is not typically fitting into this thing because there is no headache, no thunderclap headache. And we have done a vessel wall imaging also, which I'll show you the images. And we can see the some beading of vessels here. Can you see, sir? I think.
Yes.
And there is definite narrowing of the vessels here. And there is definite narrowing of the vessels here. There is segmental constriction of the vessels. And even the superior cerebral artery on the right side is showing a stenosis. And the vertebral artery is also showing a stenosis. So MR vessel wall imaging, this is the ICA, the plane. In the contrast, there is definite some enhancement of the right ICA, though it's not a very smooth circumferential enhancement. There is definite enhancement. And the left side was also showing the enhancement of the vessel wall. So we discussed with our radiologist and he told us the possibility of definite vasculitis correlating with the history of like recurrent strokes and probably the DSA imaging and the vessel wall imaging. We thought primary CNS vasculitis because there is no evidence of systemic vasculitis in the blood investigation. So we thought of suspected primary CNS vasculitis. He was started on IV solimedrol and followed by oral steroids, and we started on MMF also at the same time. So, but again, 112, she developed worsening of dysarthria and right-sided weakness. So, MRI showing new infarcts in the right crest of midbrain hemipons. So, this is left hemipons infarct. Somehow I don't have that midbrain infarct. So, patient developed a post-circulation strokes also now. So, because of the new infarcts and suspicion of this thing, so we discussed the possibility of escalating the immunosuppression with the family. So we asked them the ideal drug will be a cyclophosphamide for CNS vasculitis, but the family is not willing because when we explain the potential side effects, they are not maybe keen on starting cyclophosphamide in this patient. So this patient was started on rituximab 1 gram, and we always have a consent form. We explain the side effects, long-term side effects, short-term side effects, everything. We started rituximab 1 gram, followed by after 2 weeks, we thought we'll give another 1 gram dose. So 7/12, she developed acute headache and vomiting. So CT brain done showed left temporal hemorrhage. Actually, this is not the first image. This is showing a resolving hematoma, but actually this patient developed a new hemorrhage also. So this is the MRI of the hemorrhage, and she also had multiple cortical plus subcortical microbleeds in the MRI, and this is a diffusion showing a typical bleed. So long term, we managed after the first dose, we gave the second dose after 2 weeks. Then every 6 months, we are giving the 6 months. Every 6 months, we are giving the next dose of rituximab, and we always monitor IgG levels. One time there was a low IgG because of the rituximab. So we gave IVIG and we stopped the rituximab infusions, and we again suggested the patient has to undergo cyclophosphamide injection, because there is definitely always a chance of recurrence of stroke. But family is not very keen on starting rituximab again or cyclophosphamide. So now, so she's on maintenance dose of mycophenolate around 500 milligram BD. And the last 4 years, I think she is not having any seizures, and there is no further strokes or TIAs. But she has a mild dysarthria, mild weakness of the left side. Otherwise, she is able to manage, and she is an astrologer by profession, and she started doing consultations, online and physical consultations. And she has some emotional liability because of the bilateral strokes. Sometimes there is inappropriate laughter and a cry, and some minor dysarthria and mild weakness of the left side. But she is able to maintain all her daily activities, and she is able to do her routine. So this is the patient I just wanted to present, I think, because we had a very tough time. This is one of the VIPs of this place. And we had a very tough time in handling the patient and the patient's family. And so I just thought I'll just present and ask for your views on this patient. And there are two things which I have not done in this patient, which I thought now I should have been done, is the biopsy and the LP-CSF analysis. So raised CSF protein will definitely confirm the diagnosis of CNS vasculitis. After that, we started doing, whenever the patient is willing, we always do a CSF analysis. But biopsy, I'm not able to convince any patient till now, because we had suspected patients around more than 20-25 patients of CNS vasculitis, and they're on treatment based on the DSA and the vessel wall imaging. But I'm not able to convince the family for a brain biopsy or mental biopsy. So I just want to hear your thoughts, and maybe I will go to you, sir.
Was an angio repeated?
No, sir, we didn't repeat, sir. We didn't repeat the angio, sir, but radiologist, our interventional radiologist told this is a classical CNS vasculitis, sir. So because of the presentation, recurrent strokes.
Yes, I know, but after the treatment, we would like to know what has happened to the changes. No?
Sir?
After the treatment which has been given,
yes, sir.
Would like to know what were the changes. What are the changes on angio?
So I have not done the images, sir, but luckily she didn't have any further strokes, so we didn't repeat, sir.
Okay.
So I'll repeat at least CT angio, sir.
Let's wait for others' comments.
Yes, sir.
Sir, actually, to differentiate it from RCVS, I think a follow-up MRA or angio is required, sir. Actually,
yes, sir.
To be sure, actually. But since this patient did not have headache, only on the third episode she had headache. That could be because of raised ICT.
Yes, sir.
So raised ICT. So I think the case looks like primary CNS vasculitis only. Though angio could have been repeated to definitely rule out RCVS. And we have a question in the box, sir. Actually, we are asking whether this could be Caracel. Yes, sir.
Suresh, before that, why RCVS? There was no reversal at all. No reversible deficit at all.
No, sir. Reversible, one neurologically and another radiologically, sir. Radiologically has to be proved, sir. Then only it's RCVS. I mean, as far as I know, sir. Radiological reversal also is
correct. But why think of RCVS?
Sir.
In this context, why do you think of an RCVS?
Because there are vasoconstriction in two arterial territories, sir. One in posterior circulation, the other one in the anterior circulation.
Yeah, that could be primarily due to the vasculitis, primary vasculitis itself.
But the other differential diagnosis could be RCVS, two vasoconstrictions.
Sir, I agree, sir. We have seen RCVS also in the context of postpartum, and usually they will always present the cortical SIH, sir. And they always have, we have seen maybe 4 or 5 RCVS only, sir. But always they have definitely, when there is 3 patients, they had acute onset of headache while straining for stools. This is a classical presentation of RCVS, and always they have typical cortical subarachnoid hemorrhage, and multiple infarcts. So this is how we have seen, but in the context of what I want to stress, even though when the patient has a classical stroke risk factors like diabetes, hypertension, and the age, and when the patient has recurrent strokes, we have to always think about CNS vasculitis. That is what I just wanted to maybe convey, sir. That's why I presented this patient.
Yes, sir. Chitrambalam, Priya, other seniors, Paranjodi, all.
No, should we not rule out infective causes in all this vasculitis? Before we conclude that it's a non-infective vasculitis, should we not rule out infective vasculitis, sir?
That's what, sir. Chitraman, sir. That's why I told you I'm not done a CSR. See, this is a mistake, not a mistake. And at this thing, we didn't think of doing she was definitely off aspirin and heparin for long period because of the ICS. I should have done the LP-CSF analysis, but there is no history of any fever at the onset. There is no history of any headache. And if it is an infection, and by this time she would have succumbed to the infection, even without any treatment for specific cause of infectious cause of this infarcts and vessel wall narrowing.
Retrospectively looking back, it doesn't look like an infection because you would have had other findings. And as we go along, you should have had further deterioration, as you pointed out, and nothing to suggest an infection, isn't it? Retrospective.
Yes, sir. Retrospectively, there is no infection because patient survived for 4 years without any specific treatment.
And another thing, neurobechets also can present like this, sir. We had one case of Behçet, suspected Behçet presenting like this.
Behçet.
So Behçet usually present the brainstem syndrome, sir. We also had brainstem. We had neurobechets around 3 or 4 patients, sir. But typically, classically, they present brainstem syndrome. And I think I presented neurobechets in this forum, sir. My first neurology forum. So I presented neurobechets as the first case, sir. And the presentation is totally different, sir.
Yeah, if you have to do a biopsy, which area would have preferred this patient?
Sir, usually frontal lobe, sir, and meninges from the frontal lobe.
Yes.
And the frontal, sir.
Okay.
Prefrontal, mainly.
Yes.
So that is a question in the chat.
Sir?
There is a question in the chat. Somebody wants to know, I think Dr. Kanchana wants to know whether it could be CADASIL. And she's looking for any initial temporal lobe eye sickness. That's the question in the chat.
Yeah, CADASIL. Madam, actually, we discussed this patient with these images with 2-3 radiologists also. We didn't have the CADASIL as a possibility in this patient. Maybe I'll just go and look into it, but presentation is not typically I know. Yes, sir.
Bharti, how do you relate the initial MRI of 2017? How do you relate it to the present problem?
So just a minute, sir. Sir, how do you
relate the initial MRI of 2017 when she had a GTCS and bilateral periventricular white matter lucencies and also a temporal lobe cyst?
So she was probably had, I don't know, sir. When she came, she had a very high blood pressure. I don't know whether she had any hypertension, encephalopathy like thing in the first this thing. And I thought the small vessel ischemic changes is because of the poorly controlled hypertension.
No, the question which Kanchana has asked about a CADASIL or a CADASIL, is it related to the cyst which was found in the temporal lobe at that time?
So definitely they can have white matter ischemic changes, sir. But we discussed this MRI report with radiologists, 2-3 people, but we didn't have that CADASIL as a possibility, sir.
Yeah, no, the first MRI, do you have the 2017 MRI? Did you show them also that?
No, sir, I don't have, sir. That's the problem, sir. That's 8 years and we lost, sir.
Okay. And how about the amyloid angiopathy? Anywhere in the discussion? Does it come up?
So amyloid angiopathy usually presents with definitely this patient has a lot of cortical and subcortical
Yes, changes are there. Yes.
I agree, sir. There is a possibility of amyloid also, but amyloid usually presents maybe cortical, say, cortical bleeds and the inflammation in the brain. But this is definitely a subcortical infarct and the brainstem infarcts, and all looks like, except this lacunar strokes, except the coronary data infarcts, all looks like lacunar strokes. So I didn't think about amyloid angiopathy is a possibility, sir.
Okay.
Should we not rule out at least herpes and herpes zoster and herpes simplex because they are treatable infection-related vasculitis?
HSV, sir.
Herpes zoster.
She didn't have any zoster, sir, in the immediate past before the seizure, sir. Sorry, immediately before the stroke. But in herpes zoster, I think we'll definitely expect a large vessel occlusion. Rather than this, see here, what I want to show is the bleeding is not involving the major vessels. It's involving the second or third, like M2 and M3 like branches, distal branches. So if there is a varicella or zoster, usually it will mainly involve the proximal vessels, large vessels, rather than the D2, 3, D4, sir. So usually there will be little more proximal. So I asked Dr. Narayan sir to comment regarding this.
Regarding what, sir?
No, sir. This zoster and stroke usually involves large vessels, sir.
I think that question was posed by Chitramalam. He will be giving us further advances regarding
No, sir.
zoster vasculitis.
Yes, sir.
Yes, sir.
ANCA positive vasculitis, sir.
Weakly positive.
Yes,
sir.
Chitramalam.
Sir,
Chitramalam, sir.
Listen, but all these patients, CSF for PCR for HSV and herpes zoster, is it imperative or it depends upon the clinical situation? I'm asking VN, sir.
I do not know, sir.
Yes, sir.
I don't know. Because I have not
should we consider polyarteritis nodosa also, sir? Should we consider, because medium-sized vessels are also involved, should we consider PAN also, sir?
But there's no...
PAN will have renal involvement, sir.
No evidence of system, yeah. That's what Bala has replied, yeah. And chest involvement also.
Yes, sir.
Yes, sir. Yes, thank you, sir. Anything else, Bala, you want to say? And CTS?
No, I think regarding the management, sir, so the first line of the choice is cyclophosphamide, sir.
Yes. Other things, again, immunosuppressants, azathioprine, myclophenolate, all these also can be considered, I think. If the patient was not willing for cyclo at that point of time, I'm saying.
Yes, sir. This patient was not willing for cyclophosphamide.
Yes. At that point of time, alternate immunosuppressants could have been tried apart from rituximab.
But when cyclophosphamide is such a toxic one, I think it was started when rituximab was not available, not very widely used. But nowadays we find rituximab more comfortable than cyclophosphamide. Start with steroids and continue with rituximab. That seems to be a little better. There are some cases where yes, rituximab with steroids with rituximab, I think it is a better alternative than cyclophosphamide. Cyclophosphamide regimens a little more toxic drug, cyclophosphamide. So I think this what Bala has done with the steroid and rituximab seems to be a much smoother regimen, sir.
You could try. No, Bala was asking what else if cyclophosphamide is not there. Could try azathioprine, methotrexate, mycophenolate.
Yes,
may not be how much they are effective, we do not know, but other alternatives. CTS.
Hepatitis B, C were negative, Bala?
Negative, sir. Negative, sir. Negative. We always do serology for all stroke patients, sir.
Yes. And any FDG PET was done to rule. Think about a paraneoplastic vasculitis or anything.
No, sir. We have not done a PET, sir. Because once we saw the DSA images and the vessel imaging, we never had any other diagnosis in our mind. because of this typical recurrent strokes, there is influx as well as hemorrhages, and there is a definite vessel wall enhancement, and there is typical bleeding of the vessels. So we thought that is the first possible diagnosis in our patient. And so we discussed before starting rituximab, we discussed the imaging with maybe our radiologists and even outside radiologists to make sure that we are in a correct line, and then only we started treating the patient with rituximab, sir.
Yes, Palki,
But
you
this
were on the
vessel
correct
imaging
line.
was done with the 3 Tesla MRI, right?
No, so 1.5, sir.
But these 1.5 Tesla MRI based vessel wall imaging reliable? Because 3 Tesla machines are only good for vessel wall imaging. And how sure are the radiologists about the classical circumferential enhancement? There are a lot of artifacts and fallacies. Are they very sure about that? That too with the 1.5 Tesla?
Even atherosclerosis can have a typical enhancement, sir.
Yes.
And there are a lot of other conditions can have, but considering maybe the recurrent stroke and the possibilities and the recurrent stroke, infarct as well as hemorrhage, bleeding, we now have a protocol for suspected vasculitis. We do a CT angiogram, DSA, and vessel wall imaging.
Yes.
So if everything goes together and concordance is there in all three, we always take it as a diagnosis of a CNS vasculitis. So maybe our hospital is planning to buy a 3 Tesla,
Yes.
and we have done even better like circumferential enhancement than this patient and many patients with vasculitis. So even like we have patients like systemic vasculitis, like SLE, coming with stroke. So then we look at the vessel wall. There is definite circumferential enhancement in the vessel wall, sir.
Palki,
Yes, sir.
so far, how many primary CNS angiitis do you have?
So around more than 20, sir.
I think you should present them to us, or summarize all of those and present them to us, including the MRI and the angio appearance and the treatment response.
Yes, we are trying to gather all the patients'
Yes.
names, sir. So we thought we'll write as an article, sir.
Yes,
So,
have you discussed with Shailaja at Trivandrum? She's collecting all cases of primary and she's very much interested in this.
Yes, sir.
So you could also discuss with her and present to us, and of course you could publish it.
Yes, sir. We are planning, sir. We are in the line of collecting.
Yes.
What is the percentage of these cases where biopsy was done? Your vasculitis?
No, sir. I'm yet to convince a patient, sir.
Yes.
But we have a definite DSA evidence of vasculitis in many patients, many patients. And
Sir, Professor VN sir, I am asking, sir, we are committing the patient to a long term of immunosuppressive drugs. Is it not mandatory to make the diagnosis a little more firmly with things like biopsy, just relying on a DSA and vessel wall imaging, especially vessel wall imaging with a 1.5T MRA?
What do we do if the patient is not willing? We can't force them. We have to treat with what is available to us. And that is what Palki has done. And
Yes,
anyway, the response is there. So, supposing the patient had not responded, he was a poor responder, then probably there was some more impetus to us to go for a biopsy, press them for a biopsy. But here the patient seemed to have responded. Palki, in this patient, is she still on immunosuppressant?
Sir, actually, she had a low IgG level, sir. Usually, we don't check CD19 or 20 now. We check IgG levels before each dose of rituximab. So once she had a low IgG level, so we have to give IV immunoglobulin, sir, to replace the last immunoglobulin. Now she's only on mycophenolate, sir.
Oh, she's on mycophenolate.
After 7 doses of rituximab, her IgG levels came down, sir. So we didn't give further rituximab. We had this complication with many patients.
I have a doubt, sir. Before we call it a primary CNS vasculitis, should we not rule out all other causes? At least if biopsy patient is not willing, should we not rule out other causes like immune related, infectious causes, paraneoplastic causes, genetic causes, and all those things, sir? Before, at least without a biopsy, if we have to brand the patient as a CNS vasculitis, should we not rule out by possible investigations the other causes of vasculitis, especially infections and neoplasms? FDG PET may help, sir. And because this reliability on a vessel wall imaging, should we keep that much of reliability on a vessel wall imaging, sir? Vessel wall imaging has a lot of fallacies.
What additional information will you be getting from FTG PET?
PET or even genetic testing.
Genetic testing and FTG PET will show whether there is any evidence of occult malignancy.
No, again, if the genetic testing, how is
Yes,
it going to advance our treatment? The treatment is going to be the same whether there is a genetic, whether there is a genetic mutation or not.
Yes, sir.
And FTG PET, what are we looking for?
Any focus of sepsis or importantly malignancy, sir. Where this vasculitis is a manifestation of an occult malignancy.
I think a simple thing would be to have a CSF done if you are still suspecting it. First step is to have a CSF.
Yes,
Only
sir.
then we need to go ahead with further evaluation for a sepsis.
So
Yes,
we
sir,
are seeing a lot of patients with malignancy associated strokes, sir, because we have an oncology center with us for the last 5 years.
Yes,
So this typically is the embolic pattern.
Okay.
This is not like
Yes,
typical Lacna strokes. We don't get a Lacna strokes in this thing. See, we have had patients come first time coming with stroke, with typical embolic stroke, but we rule out all other possibilities more than 60. We always rule out malignancies. We always do a D dimer. If the D dimer is very high, and we always look for a occult malignancy. Sometimes we have picked up occult malignancy, but in the patient with already known malignancy coming with stroke, the info pattern is totally different. This is not the pattern what we definitely get it in a stroke and a malignancy.
No, I'm not telling about hypercoagulable state due to malignancy where the D dimer will be elevated, patient will have a triple tertiary sign on those. I'm telling about a vasculitis secondary to malignancy.
Vasculitis.
Because it's a stroke secondary to hypercoagulable state, patient will have a multiple triple tertiary sign and the D dimer will be elevated. That is different. But this is vasculitis secondary to malignancy. How to find out?
So I'll keep in mind, sir. I'll definitely keep in mind from the
Sir.
next.
Yes, sir.
sir.
Srinivas here, sir. Just want to add, and I think 2019 at the CPC in IAN they presented a case from PGI. It was treated as vasculitis, but a patient had an occult lymphoma, I think. And after the patient expired, they actually did a biopsy of the brain and a dissection. They could figure out that there was actually infiltration of the vessels in the brain. So it was actually secondary vascular inflammation due to it's more of lymphomatoid infiltration causing vasculitis like pictures. So I think that is what sir is trying to point out.
Yes.
Within how many months patient died?
I don't remember exactly. This was 6 years back, but I think something like it was the patient worsened over 4 months or 6 months. But I agree in your case with a long history, or maybe the rituximab was treating the lymphoma also, so we don't know. So that is again a possibility we have to keep in mind.
No, we started rituximab for the last 2 years. So
Yes,
she is now doing fine.
Yes, sir. That's what I said. She did receive lymphoma rituximab, so maybe that had a beneficial effect for both of them.
Retrospectively, we can, but at the time of diagnosis, when you start rituximab and steroid, branding it as a primary CNS vasculitis, simple PET, I think it's a very non-invasive investigation which will help to rule out some of them. And the CSF for HSV and herpes zoster, not necessary that patient had a recent chicken pox or herpes zoster, not necessary. The same applies to HSV also. So it can get activated and it can be only in the primary, it can only cause CNS vasculitis. So all these things need not have other area involvement, other stigmata. So better to do a CSF to rule out these treatable infections and to do a PET to see whether there is an occult malignancy which presents as CNS vasculitis.
Okay, accepted, sir. I'll just maybe try to include in our list of investigation in the next week.
We'll go for the second case. I think we are getting, it's 40 minutes now. So
Yes,
I think the case
Suresh, please go ahead.
The case looks like a primary CNS vasculitis. It's a wonderful case. And now, as Chittambalam sir pointed out, other investigations can be done. It's a wonderful presentation, sir. This is a wonderful case of CNS vasculitis. Now I ask you to present the second case, sir, about myasthenia.
Yes, sir. Can you see the slide, sir?
Yes, sir.
Can you see the slides? Yes, sir. So this is when she came to us, she was around 19 years, and there is a history like from 3 years of age. She noticed her drooping of both eyelids, and she has undue fatigability and difficulty in climbing upstairs. And she consulted in nearby hospitals, and they have diagnosed as a myasthenia, and she was started on neostigmine. And she has some minor improvement with the symptoms, but she never had a complete relief of symptoms. So she came to us in 2019 when there is an influenza peak with cold and cough and breathlessness with worsening of 2 days. And she had a high blood pressure and she had a hypoxia and she was started on NIV. And when we looked at her, she was fully conscious. She had a complete external ophthalmoplegia. She had a bilateral ptosis, asymmetrical. Eye closure was weak, and visual fields are complete. And there is no facial weakness. And bulk is normal, but there is asymmetrical quadriparesis in all four limbs, predominantly in the proximal. The reflexes were normal, and plantar was flexor, and neck flexor weakness was present. Neck muscle was weak, so the diaphragm, and there is no sensory involvement or no cerebellar signs or no signs of manual irritation. So for respiratory failure, she was treated with NIV for 5 days, and she gained some muscle power in the respiratory muscles. Neck is slightly improved, and she's able to walk. But she had a residual quadriparesis and complete external ophthalmoplegia, and she was able to attend the school and she was able to attend college, though she had some difficulty. So she's with the difficulty, she used to climb the bus and goes to the college. So this is the video I'll play. And there is I have another video of a battling of gait, but I didn't have it. I couldn't attach it. So this is the routine blood investigations were normal. Chest X-ray was normal. Throat swab was positive for influenza A virus, and she was treated with though this erythromycin should not be given macrolides, but somehow it was started. And ACH antibodies are around 0.31, this is equal kill. So then Musk antibodies are negative. RNS is very classically positive for postsynaptic neuromuscular junction disorders. So she had a flaccid weakness after the discharge, and she was started on Gravita, and she had a persistent proximal muscle weakness, asymmetrical quadriparesis, and CPK was around 323. We thought we'll start steroids and started on steroids, but she had a weight gain and worsening of some muscle weakness. So in April 2021, she had the worsening of the weakness, so steroid was tapered. And I didn't have the guts to start immunosuppression like mycophenolate, because from the first I didn't think it is the autoimmune myasthenia. So she had in between, she had some breathlessness and worsening of symptoms. There is some fluctuation in the symptoms as the diurnal fluctuations, as well as some months she will be all right, some months she will be sick. And in 2023, she had again worsening. We didn't have any different diagnosis. We thought we'll recheck ACH receptor antibody, but ACH receptor antibody negative. So, and she had some dysphonia also. So before maybe I just go into the final thing. So I just want to ask the possibility of, this is typically a myasthenic syndrome presented from the age of 3 years, and she had one episode of crisis also. So I just want maybe your opinion regarding the further diagnosis or differential diagnosis.
Congenital myasthenic syndromes have to be ruled out, sir. Congenital myasthenic syndromes.
Yes, sir.
DOC7.
So any other possibility, sir, other than congenital myasthenic syndromes? Okay, I'll just go. So this is this thing.
Mitochondrials.
Yes, I referred this patient to Dr. Madhusudan, sir, and he suggested, I think we have to do a whole exon sequencing. So we have done a whole exon sequencing, CR positive CHRNE mutation positive, and a slow channel myasthenic syndrome 4A. So and acetylcholine is receptor deficiency. So this is pathogenic mutation. This is a slow channel syndrome. So this is the positive this thing, homozygous. This is a homozygous, and AR. And now she is started on astatine, salbutamol. Yes, sir, salbutamol. So started with 2 doses, and now she's on 2 milligram 3 times a day. Sorry, 2 milligram, 3 tablets 3 times a day, and with small dose of good dose of gravitar also. And definitely she's much better, though she has some residual weakness of extraocular muscles and ptosis and even mild respiratory muscle weakness, but she's at least able to lead a little more better life than the before. So this patient came like some 5-6 years back to us, and maybe in only 2 years back we could make her a definite diagnosis and start a definitive treatment. And she's doing definitely well, but I don't know whether we should have diagnosed at the age of 3 years. She would have been normal by this time. At least no crises, and her quality of life would have been definitely much better. So I just wanted to present because this is a very interesting case of congenital myasthenic syndrome, slow channel syndrome, where we have a definite treatment available, but actually we have not done the genetic testing in the when she came to us in the first time. So when we had reviewed all the reviews, discharge summary, so in the 2019 discharge summary, we have definitely made a possibility of a congenital myasthenic syndrome. Was written by us, discussion with, we usually have a discussion with our team. We are suspected, but we are not done with the genetic testing. So definitely this genetic testing was very much delayed in this patient. So
Sir, I have a doubt. I mean, for slow channel, whether we can continue Gravitor, sir? For it's a slow channel, right, sir? Your biopsy.
Yes, sir. But there is acetylcholine receptor deficiency is also given, sir.
I'm asking because I don't know. Because as far as I know, for slow channel, I mean, predose segment is contraindicated. That's what I've read. I'm just asking you, sir.
Yes, sir. I discussed with Madhusudanan sir also, sir. Sir told maybe we can give also. That's what he told me. I'll also read up, sir. I'll stop the gravitas, sir.
For this particular case, I think definitely predose segment is very useful.
CTS.
Where there is a acetylcholine receptor deficiency, acetylcholine, I mean, predose segment is indicated, sir. Suresh, sir.
Oh, okay.
No, CTS.
Yes, sir.
Is it contraindicated
along with
or
yes,
is it not effective? See,
it is ineffective, sir.
Pardon?
This particular
leave alone this particular patient. This patient has ACHR positive, so the absolutely is right in giving it. But Suresh's contention is in congenital myasthenic syndromes,
for slow channel, sir,
is contraindicated. I don't think it's contraindicated. It's not effective.
It's avoided, and usually you give this salbutamol, and I think fluoxetine also can be given, sir.
Yes, it can be given.
The contraindication
depends upon the gene, sir. If the DOX7 gene or COL-Q gene, I think predose segment is not very safe, sir. But in patients with this particular syndrome where there is acetylcholine receptor deficiency, like acquired myasthenia, predose segment definitely has a role, sir.
See, initially, of course, in every patient, before landing on the diagnosis with a genetic study, every patient would have been invariably put on predose segment. Almost every patient, every child. Of course, nothing happens to them. And in fact, Balaji, unfortunately, is not here. I searched for him in the board. Balaji has quite a number of cases of this. Yes. He's not here today to talk on it. Okay.
Yes, sir. In suspected myasthenia, congenital myasthenia, better to do the gene workup and focus the treatment depending upon the gene positivity.
Yes, sir.
Because this particular gene responds to predose segment, and if it happens to be a DOX7 or COL-Q gene, probably predose segment may be harmful also.
Yes, sir. In the past 10 years, it's available, and so it can be done. But before that, it was not there. So several patients had been put on predose segment for what of anything else, and because we did not have the knowledge of genetic abnormality. So now, of course, yes, with the gene studies, that's being done.
And now the whole exome sequencing is available at a cheaper rate also, sir. It is available. It can be done for 11,500, 12,000 itself.
13,000, I think.
11,500, they are doing it in Lister nowadays, sir.
For Chittambalam, sir, special rate, sir.
Yes, sir.
So,
yes, sir.
I just wanted to present because this is long history, and maybe we have delayed our genetic diagnosis, sir. That's one. That's why I just wanted to present. Yes, sir.
Great case, sir.
Yes, sir. Thank you, Bala.
Thank you,
Thank
sir.
you, Bala. Bala, good, so good.
Thank you,
Both
sir.
the cases were good, very good.
Yes, sir. Practically useful, sir.
Yes,
That's why
sir.
we come for Bala's cases. Yes.
Sir. Chitrana, sir, we learn a lot of things
And
from
Chitramalam, sir, enlightenment.
Sir, only one question, sir. Sorry, sir. Srinivas here, sir. Sir,
Yeah,
was there any double CMAP on the testing, sir? Now testing, sir. Sometimes it can happen in slow channel
Slow
syndrome.
channel double CMAP irukanu kekkraaru.
Illa, sir. This patient's NCS, because we lost this, sir. But
Okay,
she didn't
sir.
have a double CMAP. She didn't have any double CMAP.
Okay. Okay, sir. Okay.
Thank you, Srinivas. Yes, we should have.
I'll stop sharing, sir. So I'll ask our AP to just share his case, sir.
Sanjova?
Yes, sir.
Okay, sir.
Yes.
Over to Dr. Sanjo, sir.
Thank you, Bala. Thank you once again.
Yes, sir. Welcome, sir.
On the 20 cases of PACNS podunga.
Kandipa, sir. We'll do.
CTS, meanwhile, you can ask any other comments from the audience on these two cases.
Yes, sir. Any comments, sir? I mean, there are a few questions.
There are a lot of people who
I think
will
all
have
that has been discussed, sir. I mean, I just saw the chat. Ramakrishnan sir had asked about pyridostigmine, and that has been already discussed, sir.
யார் ராமகிருஷ்ணனா?
Ramakrishnan sir.
என்ன கேக்குறாரு பைரோஸ்டிக்மினை பத்தி?
Telling
He's
sir,
telling me.
pyridostigmine. Yes, sir. Pyridostigmine initially itself, actually, first pyridostigmine trial we will use, sir. If they do not respond, then clinically itself we will consider the slow channel syndrome, DOG7 mutation and all. So it is not contraindicated. It will not be that effective, sir.
Yes, sir. Thank you, sir. Thank you, sir.
Sir, can we invite
anything else, Ramki? Anything else? Any other congenital myasthenic syndromes should be considered here apart from slow channel?
Sir, here, because the response is toward these one DOG7, sir, then RAPSIN mutation, sir, and slow channel syndrome, sir. Generally, these are the things we will consider, sir.
Yeah. And the treatment for each one of them, slow channel, we give this salbutamol.
Yes,
DOG7
sir.
also it is effective to some extent.
Yes,
Am I right? It is effective.
Yes,
And
sir,
for
the other one which we can use
Rapsin,
is 3,4-diaminopyridine, sir, which we don't have, sir.
correct. அது கிடைக்கல நமக்கு நம்ம பேஷண்ட்ஸ் கூட கிடைக்கல. What about
Yes,
Rapsin? Rapsin okay நான் கொடுக்கிறேன்.
Rapsin க்கு இதே தான் சார், வேற ஒன்றும் ஸ்பெசிஃபிக்கா இல்லைங்க சார். சில பேஷண்ட் I have tried this dalpapridine, but
yeah, correct. It's not that effective. அது பாலாஜி கூட ட்ரை பண்ணாரு, ஒன்னும் எஃபெக்டிவா இல்ல அவ்வளவு.
ஆமாங்க சார், அது அவ்வளவு எஃபெக்டிவா இல்லைங்க சார்.
இருக்கல இது ஆஸ்டாலின் தான், சால்புட்டமால் தான் ஓரளவுக்கு சம் ரிலீஃப் கொடுக்குது.
ஆனா என்னன்னா சார், for astaline we have to wait for at least 2 to 3 months for the effect to start appearing, sir. We should not be நம்ம ரொம்ப டக்குன்னு ரெஸ்பான்ஸ் வரும், we should not expect, sir.
ஐசோப்ரெனலினுக்கு எதுவும் ரோல் இருக்கா?
ஐசோப்ரெனலின் தெரியலைங்க சார்.
சரி, ஓகே ஃபைன்.
Sir, no myasthenic syndrome is worsened by pyridoxine, sir, according to Ramki.
Yes, sir. Worsen or response effective irukadum, sir.
Will it not worsen? Some of the syndromes
Yes,
will
sir.
not.
For example, if acetylcholinesterase deficiency இருக்கிறவங்க pyridostigmine கொடுத்தா worsen ஆகும், sir. Slow channel syndrome, I don't think it worsens, sir. Response ineffective or poor ஆகும், sir.
Any particular myasthenic syndrome where pyridostigmine will worsen the syndrome.
The acetylcholine receptor deficiency இல்ல.
The esterase deficiency, sir.
Yes, sir. Yes, sir.
Okay. So it will worsen in some cases. So trial is
Yes,
a trial warranted.
Acetylcholinesterase deficiency it will worsen, sir.
Yes. So in that case, trial of pyridostigmine may not be good for patients where you do not know the diagnosis.
நான் எடுத்து நம்ம acetylcholinesterase deficiency to clinically suspect, it will be difficult, sir.
So that's why better to, when you suspect a congenital myasthenic syndrome, try to point out the gene and then treat it before giving a trial of pyridostigmine and sometimes worsening the syndrome. Is it that process?
Scientifically okay, but if you see, for example, in pediatric neurology, all those flowcharts, algorithms, this is how we follow. But probably, for example, in our genetic test, for us to get it takes 4 weeks, sir. So 4 weeks வரைக்கும் ஒண்ணு கொடுக்காம இருக்கிறது, it is little difficult, sir.
Okay.
True.
Thank you, Ramki.
Case worsen ஆனாலே அதுவே நமக்கு இது diagnostic clue தானே, sir?
Yes, sir.
Okay.
இல்ல in case ஒரு low dose கொடுத்து worsening வந்தாலே அது diagnosis can be taken as a
ஆமாங்க
diagnostic.
சார், we will stop it sir. ஏன்னா எடுத்துனே 3 to 7 milligram per kg per day sir. We won't start at 7, we'll start at 3 and then depending on the response we will follow it up sir.
Thank you.
Thank you, Ramki. Thank you.
Thank you sir.
Yes, CTS, ball is tube.
Dr. Sanjoy John is available. I mean, he's a young neurologist from PSG Hospital. He has already presented in this forum before, and his last presentation also was very excellent and lucid. And now I invite Dr. Sanjoy John to present his interesting case of neuropathy. Thank you, Sanjoy John. Please welcome.
Thank you, sir. Good afternoon, everyone. I have shared my screen. Is it visible, sir?
Yes.
Sir, it's visible.
Okay, sir. So I'm proceeding. It's an interesting case of neuropathy.
It is still in slide share. You can open it up.
Is it fine, sir? Are you able to see, sir?
Still slide share, not a full screen.
Press F5.
Are you able to see, sir?
Not
still
yet.
small only. Press your F5.
F5 press, sir.
Vasant, can you help him, please?
Are you able to see, sir?
Still
So
slide
it's not
share.
coming full screen.
Go to slide show. Slide show.
Go to slide show.
Are you able to hear now, sir?
No.
No, I think you have to select share the entire screen. Just select entire screen, sharing the entire screen.
In the
Balava.
In the bottom, you got 3. You have to go to the last one.
Entire screen, yeah.
Yes. Full screen. You must come. Yes. Go to the arrow. Down. Press that one. Press that one. Why it is not moving?
Anybody, technical support people? Anybody is there?
Sanjo, exit.
Sir.
Just stop share. Then
Yes, sir.
again go to the sharing part. Then share the whole screen.
Okay, sir.
Don't select the PowerPoint.
Okay, sir.
Just try to share the whole screen.
Select screen option there.
So is it fine, sir?
No.
Not yet.
Just make it full screen.
Go to setup slideshow.
Yes, sir. Setup slideshow. Yes, sir.
Okay.
Okay.
No, still it is not coming.
அங்க டெக் சப்போர்ட் people இருக்காங்களே.
1 minute, sir.
Yeah, please make it full screen. It's working.
Where is the sharing?
Select screen. Screen option. First option.
It's selected in the screen.
Yeah.
Is it coming, sir?
Yes.
Yes, sir. Coming, sir. Correct.
Yeah.
Sorry for the disturbance, sir. So, interesting case of neuropathy, sir. It's a 36-year-old female, non-case of hypothyroidism since 4 years on levothyroxine 50 microgram. Patient is an obese individual. Are you able to hear me, sir?
Yes, please.
Yeah. Patient is an obese individual with a BMI of 43 kilogram per meter square, and she undergone sleeve gastrectomy with 360-degree ligamentum teres cardioplegy on 7/2/2025. And after that, patient presented to us with bilateral upper and lower limb pain post-surgery. Evaluated outside for DVT in right popliteal vein on 18/2/2025 and treated with rivaroxaban initially and later switched to apixaban. Suspecting rivaroxaban myopathic or neuropathic changes bar pain. And again, they noted that the numbness present over the all four limbs in a sequential manner, not in a uniform manner of numbness, with weakness in the hand grip for the 3 weeks, followed by the numbness in the upper limb that was below the wrist joint and the lower limb below the ankle. And difficulty in walking present, with foot drop was present, and cramps below the elbow and disturbed sleep was also present for the patient in a sequential manner over 2 weeks' time. On physical examination, patient was conscious, oriented, afebrile, no pallor, no icterus cyanosis, clubbing or pedal edema, no peripheral nerve thickening or no markers of neurocutaneous markers were present, and vitals were stable. CNS examination, higher mental function was normal, cranial nerves were normal, and limb power, the distal power was more affected compared to the proximal, and it was more in the upper limb and lower limb, and the asymmetrical pattern of weakness was present. The claw hand was present and the foot drop was present for the patient. Distal was more predominantly affected. Deep tendon reflex were normal and plantars were bilateral flexor for the patient. Sensory pattern was asymmetrical and it was not a graded patterns of sensory loss was present. And cerebellar function test was normal and autonomic function normal with spine and cranial normal. With other system examination was also normal for undergone sleeve gastrectomy. Hello, sir. Hello.
You are audible. Carry on.
36-year-old female with hypothyroidism and obesity undergone sleeve gastrectomy with subacute onset distal asymmetrical non-length dependent progressive painful neuropathy. Sensory to begin with, followed by with involvement with no bowel or bladder involvement. So differential diagnosis thought were post-surgical neuropathy and toxic neuropathy or vasculitis, and Hansen's, Madsen, and DM was thought of. And we proceeded with the routine blood investigation. As the patient is a hypothyroid, patient was having elevated TSH value was present of 6.8. Hemoglobin was 8.7 with low iron content was present. RBS, LFT, RFT, and electrolytes were normal. Vitamin levels were normal for both B1 and B12, and toxic screening was also normal. Infective profile, HIV, HBsAg, HCV, and VDRL was also normal, but ESR was elevated. Routine echocardiogram was normal, and MRI Allspine was also done routinely. It was not significant abnormality was detected. Nerve conduction study, there was a motor axonal neuropathy of bilateral, median, radial, peroneal, and right, ulnar, and tibial nerves. With the sensory axonal neuropathy of bilateral, median, radial, and right ulnar and sural nerve was present for the patient. And these are the NCS reports. And there is asymmetricity of and amplitude decrement can be seen in that NCS reports for the patient. And the vasculitis workup was done, suspecting vasculitis. C3 and C4 level was normal, and homocysteine level was also normal for the patient. And ANA profile, ANCA was negative, and ANA was negative, and APLA was negative for the patient. The sural nerve biopsy was done. There was an axonal loss was present with multifocal, both small and large myelinated fibers. And blood vessel changes were suggestive of vasculitis with fibrinoid necrosis and infiltration of epineural arterial wall by lymphomononuclear cell infiltrates. Inflammation was present with perineural lymphomononuclear cell infiltrates was present. This is the picture showing the fibrinoid necrosis of the patient. So the patient management plan was rheumatologist opinion was sorted out, and a nerve biopsy report has been suggestive of fibrinoid necrosis as already told of vasculitic neuropathy. So as ANA, APLA and all examination was normal and there was no systemic involvement. Non-systemic vasculitic neuropathy was thought of with multiple mononeuropathy and advice of methylprednisolone 1 gram for 3 days. Then prednisolone in a tapering dose has been given. And monthly cyclophosphamide 6 doses starting at 700 milligram has been given for the patient. And follow-up also in first visit, that is 15/4/2025, bilateral lower limb pain, numbness with poor hand grip was present with foot drop, all were improving. And the patient was given the first dose of injection cyclophosphamide 700 milligram according to the protocol. And the second visit 16/5/2025, and there is a power was improving and sensation was also improving for the patient. And the patient was not having any other side effects or the bleeding manifestation of cyclophosphamide. And third visit, the right upper limb index finger was there was a numbness, but unable to feel even too hot or cold. But lower limb numbness were better, and patient was treated with cyclophosphamide injection. So this was that case for that patient, sir. Any opinion or any other advice from your side, sir? Hello, sir.
Yes.
Yes, sir. And this follow-up has been done for the patient, sir. So non-systemic vasculitic neuropathy is a necrotizing vasculitis with peripheral nerve and skeletal muscles, and biopsy proven. This is the importance of biopsy proven with systemic and other involvement are not present for the patient. So has been labeled as non-systemic vasculitis for this patient, sir.
What is the relation to the gastrectomy?
So gastrectomy, post-gastrectomy patient, this is not related to gastrectomy, sir. Initially, we thought of post-surgical neuropathy for this patient, sir. So after gastrectomy or post-surgery, patient can have vitamin deficiency that can present with...
Yeah, correct. That's okay. I was asking about the vasculitic neuropathy. Is there any relation?
Sir. Vasculitic neuropathy, initially we thought of any other surgery that is causing the patient to have neuropathy, sir. But biopsy report has been done and it is not in a sticking pattern of any other vitamin deficiency for the patient, sir.
What Sar is asking is, can bariatric surgery predispose to vasculitic neuropathy? That's what Sar is asking.
Exactly. Yes.
Actually,
like how it can induce an autoimmune process and present as a Guillain-Barré syndrome after 2 to 3 months, because here this is again an immune process. Can bariatric surgery predispose to a vasculitic neuropathy?
Because it is closely related to the surgery.
Yes, sir.
Actually, there are some reports that the patient can have an inflammatory reaction following the surgery. And also there is some reports that there will be vitamin deficiency and also inflammatory reports following the surgery, sir. But the cause, how it is producing that inflammatory reaction following surgery is understood, sir. There can be a stress and inflammation can be there. But whether it is as such related to vasculitic neuropathy is questionable, sir.
But are there reports? Is there any reports about that? But
there are some reports, sir.
Any reports?
Reports are there, sir. Post-surgical neuropathy, there is an inflammatory process going on. Along with that, there may be the vitamin deficiency and inflammatory response that predispose the patient for a neuropathic changes, sir. There are reports are available, sir.
Sir, that's what we see in the bariatric surgery. The problem is how it can trigger GBS so late, after 2 to 3 months. This way, because it is a potential immune trigger. So can we have? So there are, I think there are reports of vasculitic neuropathy triggered by bariatric surgery also. Have you come across those reports?
As such, vasculitic surgery, vasculitic neuropathy, there is as such no reports are there, sir. But the inflammatory response and GBS only has been reported, sir. Neuropathic triggering is only reported, sir. As such, vasculitic neuropathy is not there, sir.
It's rare, but can occur, right?
But again, the surgical team will ask you to write no relation to bariatric surgery. That's what we do for our GBS also. So once we make a diagnosis of post-bariatric surgery GBS, the operating team will come and request us, please remove that and call it GBS only. So that we have done many times.
Okay, sir.
Chitramalam, sir. I think the pathogenesis is not all that clear.
Yes, sir.
Pathogenesis in relation to bariatric surgery, apart from nutrition, why should bariatric surgery cause a vasculitis? As you said, unless it's an immune-mediated process.
Yes, sir.
Is that what you're saying? It's an immune-mediated process.
Yes, sir. Yes, sir. This some immune confusion occurs. The immune system gets confused by the bariatric surgery and it triggers various processes. Probably we have definitely come across GBS. Why not a vasculitic neuropathy? That's what I was. Non-systemic, that too. Non-systemic, because it has some anger against the nerves, the nervous system. Bariatric surgery is a little angry with the nervous system. So when it produces a GBS, why not a non-systemic vasculitis? That's what I was asking, sir.
So here this patient is presented because when we always think about vascular neuropathy, we always look for evidence of systemic vasculitis. So around 50% of patients, they can have only, without evidence of systemic vasculitis, they can have a non-systemic vascular neuropathy. That is the aim of presenting this. And we have searched in the net whether there is any evidence, any correlation between pediatric surgery and the vascular neuropathy. But there is evidence of neuropathy is given, but not vascular neuropathy.
Okay.
As Sanjay told. So probably, and she also had one episode of DVT. So we, I think we discussed, Sanjo and me discussed about regarding this patient. So we thought there is no evidence of vasculitis now, and because the patient had a history of DVT also,
yes,
and, probably not related to the maybe. So she may have evidence of other systemic vasculitis in the later part of her life.
yes.
So that's what we are just thinking. It may turn out to be a systemic vasculitis with the neuropathy, probably later on, but first system is involved now. Here is the nerves. So it's very unlikely of a systemic vasculitis. So that is why we just wanted to present this patient.
When you say non-systemic vasculitis neuropathy, what are we meaning? We are saying that's primary nervous tissue involvement, primary neural vasculitis. Is that what you are saying?
Yes, sir. We had another 2 patients in the past. There is one patient who came with only foot drop, but severely painful foot drop. So perennial neuropathy. So we had done a biopsy, it was showing a vasculitis. So we have seen non-systemic vasculitic neuropathy involving typically a mononeuropathy also. So I have seen in the past. So mononeuropathy, only one nerve is involved, but severely painful. So that's why we thought, okay, we'll do a biopsy to exclude a vasculitis. That patient had a typical vasculitis in the nerve biopsy. So why I'm just saying is we can have vasculitic neuropathy without evidence of systemic vasculitis, but definitely we have to look for evidence of development of other system involvement in the later part of the patient's life to definitely say it's only restricted to nerves, or it is maybe going to involve other systems also. That we have to wait and see whether other system involvement will comes later.
Yeah, as Chitramalam asked, is there an acute insult to the cause of this vasculitic neuropathy, whatever it might be?
So other than this bariatric surgery, there is we couldn't relate anything, sir, to this thing.
No, in your other cases also, you had other cases of.
No, sir, no triggers, sir, no triggers.
What was the CVT due to?
DVT.
No, DVT, sorry, DVT.
DVT, we don't know whether dehydration. We don't know this. Definitely, it was first the patient was treated in outside other hospital. Actually, the patient was referred only for neuropathy to our hospital.
Okay.
And, when we started evaluating the cause for peripheral neuropathy, then we could find it's a non-systemic vasculitic neuropathy. Even the last picture in this patient, I think the ulnar part is very much improved. The median part is not involved. Not maybe well improved. This 2 fingers. Yeah.
The biopsy report was vasculitic neuropathy, isn't it?
Necrotizing vasculitis, sir. Necrotizing vasculitis.
Okay. Necrotizing vasculitis. Okay. Does it add anything further? Necrotizing?
Necrotizing, maybe aggressive form. That's all, sir. Is aggressive form of vasculitis. I think. Sanjo?
Yes, sir. As such, it will not add anything, sir. As such, necrotizing form. It's a type of vasculitic, and necrosis only cause more harm. That is only we can tell, sir.
And she has responded to immunosuppressants.
Yes, sir. With cyclophosphamide, she has responded, sir. And methylprednisolone initially has been given, and cyclophosphamide she has been given, and there is an improvement also was there for the patient, sir, for that initial treatment itself, sir.
And she's being continued.
Yes, sir.
But also there are interesting reports of neuropathy reversing with bariatric surgery. That also we should keep in mind. Patients with neuropathy who have undergone bariatric surgery, they have gone to wonderful reversal of the neuropathy and improvement. So that is also there. So bariatric
Why does that happen, Chitramalam, sir? Why does a reversal happen after bariatric surgery?
I don't know, sir. We have heard of that reversal happening with surgeries also. So. So when we had this DBS, when we blamed the bariatric surgery, they said it can also, not that always it damages, it also reverses some neuropathies. And that case I have to see, sir. I will tell you, sir.
Thank you. Sanjay, you have one more case, is it?
No, sir. No, sir. This is my only case, sir. Only three
Oh,
cases.
interesting case of neuropathies you mentioned.
This is this case, sir. Interesting case of neuropathy. Initial slide is this thing.
Okay. Right.
This is a
Yes.
case. Thank you, sir.
Yes, Suresh Saab, Professor Suresh.
Yes, sir.
Any
It was
other
a wonderful day,
discussions?
sir.
Any other discussions? So this is a mononeuropathy multiplex.
Yes, sir. Yes, sir. Presented like mononeuropathy multiplex, sir.
Sir, this isolated mononeuropathy, painful mononeuropathy presenting as secondary to vasculitis, they respond well to steroids.
Yes.
And they're usually short lasting. They go for a week's time or 2 weeks. I've seen 4-5 cases that they come with median neuropathy. We think of carpal tunnel, but the important clue is the pain. The pain is, non-carpal tunnel pain like, and they improve well with steroids. And that's
Yes,
a point which I wanted to tell, sir.
Yes, sir. The other patient I told you, I gave only steroids, sir. So
They improve very well.
Very well, sir. Very well, sir.
Very well. Very
So
well.
they are all non-systemic vasculitis or systemic vasculitis?
No, non-systemic.
What I can tell you is I saw mainly of they presented like carpal tunnel. They present like a median neuropathy, but we think of carpal tunnel, but it's not carpal tunnel. For these patients, they will do ultrasound of the carpal tunnel too. Ultrasound of the carpal tunnel to rule out compression, and then give a trial of steroids, and they improve really well.
No, that happens. But how do you know they were vasculitic neuropathy situation?
How do you know that it's a vasculitis?
Sir, I'm not telling it's vasculitis.
How do you know
it's a steroid responsive neuropathy.
Oh,
steroid responsive neuropathy.
Yeah, several
vasculopathy.
Any systemic disorder also can involve focal nerves. It may be a Jagran or any systemic disorder. It can involve only focal part of the nerve and cause neuritis. We have seen systemic disorders presenting as focal neuritis of a particular nerve alone. So that presentation is also there. So even if it is a focal involvement of a particular single nerve, it is imperative to rule out systemic inflammatory disorders with an ANA profile and other tests.
So I told you the two other patients presented with non-systemic vascular neuropathy.
Yes.
We have done a biopsy and we proved it is vasculitis. Not like we just tried only steroids. We have proved it's vasculitis. So I think it's very interesting. So I think all of us might have seen this kind of presentation. So just wanted to.
What nerves were there? Which nerves were biopsied? All were sural in these cases or what? If it is some other nerve, how do you biopsy?
No, I had only in lower limb, sir. This is a patient presented with multiple mononeuropathy. So other two patients had come with a foot drop. So painful foot drop. So we do a sural nerve biopsy and prove it's vasculitis.
In this case, which now sample?
Sural nerve biopsy has been done.
Along with the muscle also, you usually do sural and a muscle, isn't it? For vasculitis particularly, you also take a little bit of muscle.
Yes, sir.
For muscle and nerve biopsy.
Yeah.
That is only for superficial peroneal, sir. All sural also, sir. Only if it is superficial peroneal,
you go in.
Biopsy,
usually, when you plan it, you go for that. A combined one. Yes. Particularly when you are suspecting vasculitis, the combined approach is better, muscle and nerve.
Yes, sir.
Yes, Bala, anything else you want to add? Nadesan sir, you have any questions, sir?
No, sir. Only no, sir.
Thank you, sir. Thank you, sir.
Thank you.
Balki, anything to add?
No, Dr. Shailaja தான் பிரசன்ட் பண்ணாங்களே அந்த பிரைமரி வாஸ்குலரைசேஷன் நம்ம இதுல.
ஆமா.
I was questioning here in the prevalence of extensive tuberculosis in India. How are you sure we are dealing only with the primary vasculitis? And she had no answer. So vasculitis infective component, as Tremblon said, must be considered.
Yes, sir. That has to be there. Yes, that's true.
That is not, I accept
the
it.
points which Chitrambalam raised are quite valid. HSV or HZV, which can be silent and can trigger up and can show up only with vasculitis involvement, can happen. Yes, it is known. But the point is whether every patient needs to be submitted when the patient shows a response. See, so far we have not been doing, even biopsy we have not been doing. We have been only treating, and when the response is there, we are satisfied with that and we have left it at that. Of course,
Sir, steroid response in most cases is erroneous and misleading, sir.
No, I am talking of when you got an evidence, beaded appearance of the vessel wall, and you think it's a vasculitis, and you treat the patient responds. We don't proceed to a biopsy in such patients.
As Chitrambalam said, repeat MRI might have helped.
Yeah, repeat MRI, I also asked for it. I asked for a repeat angiographic study itself. Yes. But Chitrambalam's point was it could still be infection, so FTG PET should be done and should be evaluated for sepsis. Of course, CSF agreed to, but he also said FTG PET should be done in such patients to detect an occult. I mean, in other words, there may be a long-standing occult infection, smoldering infection, which could trigger off the vasculitic process. That's what that was his contention.
Sir, I have a small. So anybody who was maybe attending this is able to convince the patient for a biopsy, sir? So, I don't know, sir, because I am trying to convince the patient, but once you say biopsy, they just back up. So
biopsy, particularly biopsy, brain vessel biopsy, particularly unless the patient is non-responsive, it is very difficult to convince.
Sir, anybody has done it, sir. So because I'm just
people could have done it. We do not know. We do not have. See, that's why collection of cases is important. Yes, see, sir. What Shailaja is doing is she's going for a registry, collection of primary CNS vasculitis, a registry. So if we get more numbers from different centers, we would get to know what has been done in those centers. Somewhere somebody could have done it. We don't know. So answer is not known. But certainly people could have asked for a biopsy. It could have been done. So, for example, in Sri Chitra might have done, Nimans could have done, the central institutions could have done. We don't know.
No. Now in our group, maybe people who are now attending today's meetings, are anybody able to convince her? Because now.
No, Balakrishna, it's very difficult.
I understand, sir. That's why
they changed the doctor.
Yeah.
You are absolutely right. You had the patient, you diagnosed properly, you worked them up as much as you can, and you also showed the result with the steroid suppressant. So this is only learning, not learning what else could be done in such patients was what was highlighted.
Yes, sir.
But if the patient had not responded, yes, we would have gone for a biopsy.
Yes, sir. Yes, sir.
And if it is a superficial one, probably you could, some of the lead, which is a superficial lesion, could be submitted for biopsy. But these were deep lesions, if I am right.
Yes, sir. Thank you, sir. Thank you, Natal.
Thank you, Suresh.
Thank you, sir.
No, I should thank all of you, Bala, Sanjo, Suresh, and of course the star batter, Chitrambalam, for all the questions and provoking the discussion.
Yes, Everang Chitrambalam, sir, never gets aged, sir.
அவர் உங்களை சொல்றாரு, நீங்க அவரை சொல்றீங்க.
இல்ல சார், அவருடைய அந்த துடிப்பு சார், எந்த நேரமும் அவர் துடிப்போடவே இருக்காரு சார். Great day, sir. I think, thank you, sir. Thanks for all.
We'll read about all those topics again, sir. It's very, very useful, practically very important topics, sir.
Balki,
yes, sir.
வரதுக்கு முன்னாடியே நான் சிற்றம்பலத்தை கேட்டேன். என்ன unusual இல்ல. He drops in now and then. என்ன சிற்றம்பலம், what has attracted you அப்படின்னு. No, is it Suresh being there? Suresh illa, Balki is there. They're all, and the cases are very interesting. I wanted to attempt these cases. அப்படின்னு சொல்லி தான் அவர் சொன்னார்.
Okay, sir. Okay, sir. Thank you, sir. Thank you, Chitranam, sir.
Thank you, Bala. Thank you.
Thank you, sir.
Yes, sir.
Thank
Thank you, sir.
All of you. And thank Sun Pharma as usual for your support as always. And we continue. Thank you, Vasant, and the tech team. Thank you.
Thank you.
Thank you.
Sun team and others.
Okay, sir. Okay, sir. Thanks.
No,
Okay.
Just hold on. Just hold on. Next month, it is on 20th July. And Priya and Tangaraj of Dhanlakshmi Srinivasan, they will be presenting the cases.
Sure, sir. Sure, sir. Okay, sir.
Next month.
Sure, sir.
August we are presenting, sir.
Huh?
August we are presenting, sir.
August Priya, yes.
No, sir.
Correct.
August Priya.
August Priya presenting in the month of July.
Yes, sir.
Okay.
Okay, sir.
Thank you.
Priya was there today also. I don't know why she has not participated. Thank you. Thank all of you.
Thank you, sir. Thank you.
Thank you, sir. Thank you, Nara.